Okay, perfect. Now we're official.
Sounds good.
Cool. Um, so first thing, do you go by Melody or a short version of your name?
I love it. Actually, that's the first time anyone's ever asked me that. I go by Mel. But
Right on.
really only my family calls me that. Professionally now, most people just call me Melody. But I also answer to RT, hey you, that random person over there, anything like that.
Right on.
Melissa, Melanie, anything that's remotely an M name. But Mel
Nice.
is great too. Whatever you want to call me is good.
Perfect. Well, we'll go with Mel then.
And what do you prefer? Like Ryan's pretty short, so it's not.
Yeah, Ryan doesn't have any like shortened version, so Ryan is totally fine.
Okay, sounds good.
Cool. Um, yeah, I guess we got in touch because you have a page on Instagram that does like education about respiratory therapy stuff. And I think I found out about it from Mike at the World's Okayest Medic podcast. Because I think you chatted with him or he like reshared something of yours. And you have a book that you published that's available for free on like mechanical ventilation.
Yeah.
What's the story with that? I'm curious to know like why you put a book out for free, and mainly because everyone always asks me the same question.
Yes, because I know of your book and I actually knew of your book before. Kudos, by the way. I love it. It's amazing. It's much higher level. It gets into more of the weeds than I did in mine, but I'll get into that in a second. I do want to just shout out to Mike because Crunch definitely was the reason I even started Instagram. He like had me on his podcast just because he thought I was funny when I messaged him on Instagram. And it started a beautiful friendship, and then he kind of pushed me annoyingly hard, and I finally like ripped the band-aid and started my Instagram page. But prior to that, um just like around COVID, I was looking around for different mechanical ventilation books, and at that time I hadn't seen yours. And I had seen like books for ventilation that were written by paramedics, and I had seen, of course, there's textbooks written by physicians, but I didn't really see anything that was written by an RT. And I was like, there really should be an RT voice in this, because I think being a non-physician designation, we have an expertise in ventilation, but also a way to maybe simplify the concepts and bring it down from maybe a physician level or intensivist level, where they might get into more of the studies and the research and be able to explain things in language that's easy to understand. And also, coming from a standpoint from respiratory therapy, with our background and being in a hospital and being very immersed in best practice medicine, kind of moving out of maybe some of the practices, and I don't want to come off as speaking down to any profession, because that's not it at all. But sometimes when you have a silo of paramedics teaching paramedics or nurses teaching nurses, you don't necessarily get a complete picture of best practice when it comes to ventilation. So, and I had seen a little bit of that specifically with my hate on for SIMV that I'm always very honest about, that I would see that a lot in books that were written by paramedics of still teaching it as a mode that's used quite heavily. So, anyways, all that to say, I wanted to have a voice as an RT to be able to speak to those professions that don't necessarily have mechanical ventilation in their bread and butter of their profession, and be able to explain it in a way that's easy to understand, and within one book take someone from nothing and give them the building blocks to be able to initiate ventilation in a situation where they don't necessarily have expertise at the bedside, like a critical care paramedic or like a physician or an RT, to be safe and to not harm someone, and be able to pick settings that were appropriate for their patient, and potentially even the therapy, like non-invasive versus invasive, and the mode of ventilation. And they might not necessarily be at the level of a critical care provider, but be safe. So I wanted it to be simple, easily digestible, and within a very short period, get them to at least initiating safe settings and then moving through why you would make changes based on gases and things like that. So that was kind of where I came up with the idea of having an RT voice to do that. And I started just writing it while I was flying on like longer hauls, just in the back of the aircraft while I was flying. And then I had a wonderful resource that actually I sent the book to them, and they loved it and saw the value and merit in it, and sent it to someone that they knew who actually was connected with Sioux College. which is a college here in Canada, and they actually sponsored and partnered with me to get it a grant for it to be able to release it
Mm,
free. And that's kind of how it happened, and why I decided to write it. And I wanted to write it free to get it out because I wanted there to be absolutely no barriers to any person, regardless of their background, regardless of their familiarity with vents, to at least have something to start their journey and to start their journey in a way that isn't overwhelming or scary.
and is that group Sue, do they run like the book is published on this website that like makes it pretty easy to read online, like versus mine that's just like a PDF document. But do
Mhm.
they run that website as well? Like how did the hosting part of it work?
Yeah, so the way that the grant that they helped me get the grant, Sioux College. So they're an accredited college here in Canada, but the grant actually is through the Ontario government, and so they have an online publication database that is an open educational resources, which is what the grant was for, and it was pretty much any educational resource. It didn't have to be medical; it could be anything else. Could apply for a grant, and I had to write a proposal and the rationale and the reason why. And I honestly think COVID was worked in my favor because it was right at the time when COVID was coming up and ventilation actually was something that the public knew about and they heard
Totally.
about it on the news. And when I pitched it to them, I said, this is to increase the expertise of multiple disciplines to be able to understand mechanical ventilation. And I think those magic words were what really helped in the world of COVID to get them to be able to say, like, yes, we will publish this and we will publish it for free. So
For sure.
it's published open source, and with that copyright, it can be used by anyone. But if they use the material, they have to then publish open source as well. So it actually locks people into a gift that keeps
Mm,
giving. So they can use it. They can use all the content, but if they
interesting.
want to, they have to then publish for free as well.
Right on. Yeah, that's cool. Huh. Right
That's
on.
kind of my long drawn out story, but yes.
For sure. Yeah, and I imagine that was like ideal timing because I imagine it was the same for you guys up there. But like here in the States, we had a lot of clinicians who don't typically use ventilators or who were using ventilators that they're not used to working with, like during that time because we just had so many patients. So I think like having
Mhm.
a resource like that um, probably helped out a lot. Um, cool. And you mentioned this in your narrative about like how you started the book, but you also fly.
Not anymore. So I
Okay.
flew for 4 years. So
Okay.
now I work for a critical transport company here in
Okay.
Canada. But actually, the company that I work for is only paramedic based. It is like actually one of the sole companies that I'm aware of that has a paramedic pairing. So it's two CCPs that fly. Um,
Okay.
instead of like a paramedic nurse or physician nurse or physician paramedic like other services. So I work for them and I'm one of their educators, and I do a lot of their mechanical ventilation, airway, respiratory teaching for all their CCPs, and I absolutely love it.
Right on. And do you
Mhm.
still work in a hospital as well, or just the you do?
Yeah,
Right
I
on.
do. So I'm actually an anesthesia assistant and I'm an RT. So
Okay.
mostly when I work clinically, I now work as an RT, but I still am an anesthesia assistant. And I did work in the OR as an AA for a while, but
Awesome.
now mostly my clinical shifts are just RT.
Cool. Right on.
Mhm.
Um, well, you and I have been talking a fair amount about like all things mechanical ventilation, but I think you've seen this list as well, but I kind of put a list of questions together to ask you about. I don't know if we'll have time to get through all of them, but maybe we'll just dive into those and see where it takes us.
Absolutely. Whenever you're ready.
All right. I'm ready. So the first thing that I was curious to know is like, what do you think is maybe not the biggest difference? What are like some of the differences between how mechanical ventilation is done or taught in the hospital setting versus how it's done or taught in the transport setting?
I honestly think the main difference, there's there's not that many differences in a good program, but I think the main difference is as an RT or in the hospital environment, um, Our main ideology when it comes to ventilation is minimizing the time on the ventilator. We're not a bridge to anything. We're not getting a patient somewhere. Like once a patient is intubated, every single action and thing that I do is to get them off that ventilator. And that's what I see my job is as an RT. It's not to intubate people or to manage ventilators. It is to get people off of them. So when it comes to a normalized gas, I'm weaning that patient. When the patient has a spontaneous drive to breathe, I'm considering a spontaneous mode immediately. There is really not a place to put paralytics in for safety or to sedate people for safety because you don't need to do that. If they're breathing or they have a drive to breathe, you make them comfortable on the vent, you decrease asynchronies, and you get them off the ventilator. Versus in transport, safety is paramount. We are moving the patients around, and it does shift the mindset a bit that yes, if I have a normal gas, I'm probably not going to wean my patient. I'm probably going to let that ride, and I'll probably leave my patient deeper and not have them lighter with their sedation because I'm not necessarily winning the text debate when I know I'm about to take them out of the aircraft in a minute and disturb them. So I would honestly say that's probably the main difference, just by nature of it being in transport. That even when I was flying, I was the same way that I wasn't necessarily as aggressive.
Right on. Yeah, that makes sense.
What do you think?
Um,
Like, do you see any differences in your
I I do. I mean, I think we'll probably get into some of these, but I think, yeah, I think your take on it makes a lot of sense. That the idea of like ventilation is like you're always working to get someone off. Like in the hospital where I work, every time we come on shift, whether it's day shift or night shift, we're always doing an SAT, and if they pass it, then we'll do an SBT, and we'll try and get them off the ventilator as soon as possible. That's like always something on our to-do list. I think there's a lot of little things that are different in like how we teach it in transport versus like in the hospital. Like we spend a lot of time in transport um, talking about like some very like nuanced specific things, and like I think in the hospital side of things, they tend to have like a the approach that like maybe those little tiny things don't matter. Like for example, like in pre-hospital setting, at least where I work, we're really big on like quantifying everything in mechanical ventilation. Whereas in the hospital side, they're like, I don't know, just put them on settings and we'll run a gas, and then if we need to adjust it, we can. Um, and I don't think there's like a right or a wrong. It's just like a different approach. Um,
Yes, I actually like that you brought that up. And I know one of the questions you had sent me was about like the gestalt of a bedside RT or physician of like just kind of almost feeling your way through ventilation. You throw them on a setting, you see the volumes that they're getting, and then you're making changes, but you're not necessarily calculating or looking at
totally.
the minute ventilation and like targeting specific numbers. And like I am a big proponent of the art and the science and those two things together. And I do definitely see within um working with paramedics so closely and working with RNs closely that yes, like they want a number to hold on to and they want something to really look at. But I always try to remind them that like those numbers aren't necessarily accurate. Like then you have to dive in and dig deeper. Like you can't see the metabolism of the patient. You can't see the VQ matching specifically unless you're doing a metabolic study to see how those numbers in that minute ventilation is really going to refer to CO2 clearance. So then like you're guessing, you're still at that point guessing. And yes, maybe you're
Totally.
calculating, with this minute ventilation and this CO2, then I'd have to increase my minute ventilation by this. But then I would argue, why not improve your dead space to actual alveolar ventilation ratio a bit better, improve your VQ mismatch. And then once you do that, you'll be more effective. So there is always a bit more hand waving, I think, than most people would like it to be when it comes to ventilation. But like, as long as you're moving in the right direction, like, I don't care. If you want a number, we can go with numbers. And I do when I do my training, if they want numbers to look at, then I show them all the different calculations they can do because I know that some people like that when they're learning to have that
For sure.
safety.
Yeah, that's kind of how I've like where I've arrived at like where I work, like they're really big on numbers. So like in the workplace, like I we calculate everything out, and realistically a lot of times we like calculate it out after the fact. But like in like when I'm teaching somebody, I'd say like here's like how you would get all the numbers if you had no idea where to start. But in reality, like if you're like looking at a patient on the ventilator, like if everything looks good, if you like do your normal patient assessment stuff and like everything checks out, like just match those settings and then adjust from there. Or if you're like starting, like let's say you did the RSI, just like put them on the defaults that your machine goes to, and then like adjust from there. I think that's totally fine to do,
Yeah.
as long as you're not like, like putting a kid on the adult defaults or whatever, like within reason, of course.
Mhm.
And then like when you have a moment, you can always like do the math and like get your numbers and then like see how it compares.
Yeah, absolutely. Like I always love, teaching people when you're throwing someone on a pressure control mode, like picking a pressure control of 15, it might seem like you're just picking a number out, but then there's actually science behind that. It's like, okay, if you know if your pressure control is 15, then your driving pressure is less than 15. So you're already safe there. And if you're in, volume
Right.
ventilation, you can do the calculation for their predicted body weight. And like again, I always like again, so I like have my soapboxes again. Like I always say, measure your patient, like get your volumes and know your safe volume ranges, and then put those in. And then yeah, when it comes to your respiratory rate to go with it, like I always preach demographic norms because I'd rather have the information back from the vent to know how they're
Mm.
exhaling and whether there's gas trapping and things like that before I start to go beyond that. So I might know that I might be titrating it up, but I'm not necessarily gonna go calculate straight out and say, I need to have a respiratory rate of 27 in order to get this patient to clear CO2. Like, I'm not going to start there. I'm going to start lower. But yeah,
Yeah. How often are you or RTs in general in your system actually getting a tape measure out and measuring patients, do you think?
less than they should.
Yeah, I mean, same for us too.
Yeah.
Like I carry
I
a tape measure in my pocket on the flight suit, but like almost nobody does.
I know. I even sometimes I'll tell people like it doesn't have to be difficult. Like make the good choice easy. Whenever I work a clinical shift, and oh my goodness, don't tell my RTs I do this because I hope they think it's just a fairy. But I actually tape the disposable tape measures to every single ventilator that's circuited. So when it
Mm,
gets wheeled into the room, it's right there. But if you make that choice easy, then they do it. But like
yeah,
I'll be
yeah,
honest, there are times, oh sorry, I didn't mean to step on you there, but there are times that like I don't have a measuring tape close by, but I know that my arm span is my height. So sometimes I'll use that as an estimate before I can go grab it and then measure. Um, but yeah, it's not as much as they should for sure.
yeah, totally. Yeah, I was just gonna make a comment that like lowering that like barrier to doing the thing
Hmm.
just makes sense. Like I say the same thing when like I say it kind of in jest, but seriously, like if I set you up for an intubation, like if I'm your partner, like I'm gonna take the stylet out of the ET tube and like hand you a bougie. Like there's just like I'm gonna set you up for success. Like that way you don't have a choice. Like you just like use a thing that like gives you better success. Um, yeah. So I think like taping a tape measure to the machine makes sense. Um, yeah, I would compare it maybe to like estimating weights on patients for drug doses. Like we think we're pretty good at it, but we're probably not. So like it makes sense
Yeah.
just to like take a moment to measure somebody.
Yeah, I really suggest it because I'll be honest, my mental math, especially in times of crisis, is never as good as I think it is.
Yeah,
So
totally.
I've been off some crazy times in my career where I'm like, oh, they're probably around 6 foot, and they're like not anywhere near that, and I'm like, whoopsies.
Yeah,
It's hard to tell sometimes.
for sure. Yeah, especially when you have like a patient like bundled up or like a bunch of things piled on them and equipment, it's like kind of hard to tell.
Hmm. Now, not to
Um,
jump back in the conversation, but you mentioned like some differences in transport versus hospital, and like one thing that I have appreciated so much in my career is um, changing and moving to transport from a hospital environment and having other healthcare disciplines teach me that like especially when it came to airway and like the OR did a lot to teach me, but I appreciated so much the like how you said, like the making the best choice, like the first choice, and that like setting yourself up for every single patient that you have the worst case scenario at your forefront. And like in the OR, we're good at that, but that's something that I would say as a profession I don't see as much as I'd like to see within respiratory therapy when it comes to airway management, that they don't tend to set themselves up using, dash 1A success for like airways and really thinking about like the concerns for hypotension and hypoxia and like I even using passive oxygenation methods during their intubation and that for EMS, that's probably horrific because that was years and years ago that was brought into practice. But I still find I think they have ways to go and to move and to improve in that area, and I've appreciated so much how I've been taught in that way that I I I follow. I feel like I'm a blend of professions now from the amazing growth that I've had from different like from paramedics and nurses within working with them in the past. So it's been really amazing for me.
Yeah. Yeah, that's interesting that you mentioned that. I think like in the critical care transport in the flight world, I think like we've done a pretty decent job like encouraging everyone to do that sort of stuff. Um, I see it less in the hospital, and I have a theory that that's maybe just because there's like it's a much more like hierarchical system in the hospital. So like a junior provider like doing something that seems unusual, like there's like some resistance to that. Whereas like in our setting, like medics and nurses and whoever's like flying on the aircraft in whatever program you are in the States, for the most part, like it's a pretty level playing field. So that dynamic is maybe like attenuated or doesn't exist to some degree. Um, yeah, I don't know. I have to think about that one a little bit more.
Have you noticed that as well in the hospital? Like the things that are bread and butter to you as like as a provider that you don't necessarily see like from what you've seen in transport versus hospital?
Yeah, yeah, for sure. Like a lot of like the like pre-oxygenation stuff you were mentioning, like getting a patient's head of bed up, pre-oxygenating with like a OPA or NPA and using apneic oxygenation. Like we do
Mhm.
that stuff religiously in the field,
Yeah.
um, but I don't really see that often in the hospital. Um, yeah, I also think in general, this is like maybe not totally related to vents, but like airway management is like a huge deal to us in the pre-hospital setting. Like we put a lot of emphasis on it. Like we take a lot of pride in like doing that. Um, Whereas in the hospital, like all the clinicians, it's just one of like a whole bunch of procedures they do. And you always have like a team of people like to back you up if things go wrong. So I think there's like, it seems like the urgency to do the thing, or maybe not the urgency, because not like, it's not a sense of urgency to get it done, but like maybe the focus on it is less so. Like for us, if we like take a second attempt on an airway, it's a big deal. Like in the hospital, like I don't think anyone cares. Like it's fine. Be like, hey, it was all right. You like you didn't let the patient desat. We bagged him. Like try again. But like for us, we put like a lot of emphasis on that like first pass assess, and I think that's fine. Like I don't think there's anything wrong with it. I think it's just like a difference of priorities. Like we have something to prove, whereas like in the hospital they don't. Maybe.
I'd like to think it matters though. Like the numbers in the studies say that the more attempts you have, the more negative outcomes. But yeah, I feel like we could talk about airway like all
Yeah,
day.
for
Like
sure.
it's a
Totally.
whole other topic.
Yeah, we'll save that one for next time
I'm gonna get in trouble with all my
then.
RT. God.
um, Another thing that we do or that we talk a lot about in transport is clamping ET tubes. And I was curious to get your take on that. And then
Yeah.
I'll spill the beans about what I see like in the hospital side of things.
Oh, I see it all on the hospital side of things. Um, yeah, and I feel again like so first off, I do have to say, like, when I teach clamping, I am huge on teaching clamping on exhalation. And the reason for that is we're maintaining PEEP. And it's yes, like there is a lot of depending on the machine you use and the mode of ventilation you use, there's definitely pressure control is never going to go beyond that peak pressure. And there is often, not necessarily a huge concern whether you're clamping on inspiration. But I always say for every single ventilator, if you don't know how your ventilator works and you don't know what mode of ventilation the patient's going to be in on the other end, if you're if, excuse me, if you're in any other mode of ventilation, like a volume mode, you can have those pressures go too high. So with clamping on exhalation, you are ensuring you're not applying too much pressure to the lung to over distend or cause potentially a double stack of a breath. And every ventilator works differently. And I've had ventilators before that if it disconnects and it's on, it's going to send pressure out that could potentially, before it connects and reads the pressure back, it could expose the lung. And we don't really know. So that being said, there's that whole concern of, well, we're going to be losing pressure once we clamp. And if we don't clamp at the end of inspiration, our pressure is going to drop lower. But then I do have to say, we're not carrying this is going to sound bad, but we're not caring that much, because if that's the truth, that we're going to like absolutely collapse and have our patient like completely de-recruit in a second, we wouldn't be able to suction our patients. And we suction our patients and expose them to negative pressure, which then could cause de-recruitment, and it does cause desaturation, but they do recruit again. So when people talk about needing to give them a higher pressure when clamping and clamping at the end of inspiration to ensure that during the transition they're not going to lose too much pressure, I say we'll do suction your patients. So for safety, to maintain as much PEEP as we can, because they can de-recruit, and some ARDS patients are more sensitive, or difficult to ventilate in general. Hypoxic patients are more sensitive to de-recruitment. I suggest clamping at the end of exhalation for safety, and the reason I do that is just because you don't necessarily know what mode of ventilation they're going to be in on the other end.
Totally. Yeah, and I think this is something we've talked about before because I was always taught and teach to clamp on inhalation for that reason where like if you clamp it, like we don't know if like your clamp's gonna hold that seal, like maybe you clamp it and
Mhm.
there's like a slow leak. But I think it does make sense. Like there is the risk there that you can like stack, like you're holding like peak pressure basically, and then you're giving another breath on top of that. And we kind of talked about you could like get into the nitty gritty on this. Like if you had someone in a pressure control mode, like probably isn't that big of a deal because you're like pressure limited. Or if you like had them in a volume control, but you have like tight parameters set on your limits, then it's also like a way to mitigate that. But I think that's maybe something I would like think about revisiting and like how I teach that. Um, but in reality, like I think you make a good point that like we break the circuit all the time. Like in the hospital, like we're breaking the circuit like a handful of times a shifts, even on like super sick RZ patients. So part of me thinks that like maybe this like ET tube clamping thing like doesn't matter. It's something that we like routinely focus on in transport, but to be honest, I've never seen anyone ever do it in the hospital. So I was just like curious if that's a normal finding or just an anomaly for me.
My practice is any patient who is on a PEEP greater than 10, it is an absolute necessity to
Mm.
clamp when I'm transferring them for anything in hospital. And as best, like I would still argue for any patient that is on PEEPs that aren't just minimum, there isn't a harm in clamping, as long, even for a patient who is awake and you can talk to them and explain what you're about to do. There's no harm in doing that clamping to maintain. And I suggest just decrease the time, like make sure that it's a very quick procedure. Um, but for patients that do de-recruit, like why not? Why not clamp? Why put yourself like you're really shooting yourself in the foot. You know what's going to happen over time and that you're going to have de-recruitment, specifically with heterogeneous closing pressures of different alveoli that are more damaged than others. And yes, we may not maintain all of the pressure. We may have some pressure loss, but some pressure maintained is better than none. So I would still suggest, why not?
Yeah, I think that's a good point that like as long as you like mitigate the risk of like stacking another breath on top of like a clamp. So either by clamping at exhalation or making sure your pressure control or like having your upper, like your high pressure limit set tight. As long as you do something to prevent damage from it, I think you can like advocate that you should do it across the board. So yeah, I would agree with that. Um, cool. We'll just carry on with our list here. Um, what are your thoughts about PEEP and fluid displacement, like pushing fluid out of the lungs? This
Yeah,
is
this is a fun one, right?
yeah,
So I was taught back in the day that PEEP and pressure push fluid out of the lungs. Um, I now at this point, the way I see it is it more that PEEP can help be a bit of a stopgap to stop the leaking while the lymphatic system clears the fluid with like the shifts to like hydrostatic fluid, like pressures and all of those. But at the end of the day, realistically, what we're doing is we're just expanding the alveoli more to give more surface area. There isn't a push of fluid across that alveolar membrane. It just, the lymphatic system is what clears it more than anything. What are your
yeah,
thoughts?
yeah. I agree with you. Yeah, I think all of us were taught at one point that like PEEP pushes fluid out of the alveoli. It seems pretty clear that like the benefit in terms of oxygenation is just increased surface area. Um, but I think I'm not totally convinced that like it doesn't help displace fluid to some degree, but I think the timeline is like much more prolonged than it like would matter in most transports. Like I
Yes.
think like increasing surface area on the alveoli and like making the membrane thinner like would allow that fluid to leave more quickly over time. But I think that's like a more prolonged thing. Like my read of it is that like this is something that happens like over like hours to days, not something like you're not gonna like push all the fluid in a CHF or so lungs out in like 20 minutes on the way to the hospital.
Yeah, and I think as well, like if you are displacing fluid from the alveoli, where is it going to go? It's going to sit in the alveolar capillary membrane. Like it's not going away. And then there it's still
Yeah,
impacting the ability of oxygen to diffuse. So realistically, what needs to happen is you need to have the lymphatic system drain that fluid away. So the displacement won't help you at all because all it's going to do is still be sitting there, between the capillaries and the alveoli. So even though it may displace it out of the lung alveoli slightly, it's not displaced out of the entire system. So it's still working against you.
right.
So realistically, the body needs to clear that. And PEEP allows, potentially less leaking into the lungs, and that can then over time be cleared. So that like that's kind of how, if you really want to get into how I currently now think of it in my mind, that's kind of more of how I think about it. But now I try to just really focus more on like we're increasing surface area to allow more, you know, area for gas exchange to occur. And then like we're not necessarily pushing the fluid out. But
Right. Totally. Yeah, and I think in general, like that maybe it's just because like the transition from like working as like a ground medic to critical care, but I think that understanding of the concept is definitely like is now presented differently than when I was first learning this. It sounds like maybe the same for you. So yeah,
absolutely. And there's so many things like that that I was taught, when I was newer to the career that I've relearned over the years or like learned in a different frame or a different form. And it's crazy how all of that can, change over the span of just a few years. Like I've only been practicing now 17 years. And like I feel like what I learned back then is so vastly different to now.
yeah, yeah. And I think that yeah, I think that's bound to happen with time. Um, what are your thoughts on like a hypotensive ventilator strategy? Like doing things on the vent to like yeah, I think everyone like agrees that like putting somebody on positive pressure mechanical ventilation can like decrease blood return to the heart and cause them to become hypotensive. But what about like intentionally using a vent strategy in a hypotensive patient to like prevent it from happening to whatever degree you can?
Yeah, and I think you were referring to a specific strategy, right? When like with the question?
Yeah, so um, basically you would use like a higher tidal volume and a lower rate. So you would like basically like decrease the amount of time when you're pushing air into the lungs above your PEEP, and then you could potentially
Mhm.
even like drop your PEEP to zero. So like I guess like the most extreme version of this would be like have a tidal volume as like high as you deem safe for your patient, with a rate as low as you can to maintain whatever you think is a minimum ventilation, and then leave your PEEP at zero.
Mhm.
And that would be like the least impact you could have on like blood return to the heart on preload.
Yeah, because it's like less time under extreme pressure kind of idea and then like no
Yeah.
pressure. Yeah, I looked into it. I actually tried to look at some of the studies because I'll be honest, I'll be very honest, like I don't know close to enough about everything. And I feel like the more I hear, I'm like, I've never heard of that before. I'd never heard of this before. So in my career, I've never used a strategy like this ever, other than just focusing on diminishing or decreasing PEEP as much as
Yeah.
possible.
And to be fair, we never really have to because we in most clinical settings we have access to other things like we can give
Yeah.
fluids and pressors and like we can do all
Yes.
the other but like there is like a subset of like clinicians out there who work in like resource limited settings where like they may not have access to that stuff or maybe like on the way later.
Hmm.
um, so yeah.
Yeah, and I think that that's a valid point because whenever I hear about hypovolemia or like different strategies for that, I always say, well, like fix the problem, like try to
Totally.
support the heart, support the blood, like the blood pressure in whatever means you can that's appropriate to the type of shock that you have in order to then be able to ventilate the patient appropriately. So I guess like my concern with the idea of like, you know, hyper low rates and larger volumes. Like in the one study I read, they used volumes that were well beyond um, what is deemed, quote unquote, safe in some, like in the schools of like ARDSNet studies that we've had from 25 years ago now of like, 12 mils per kilo was the study that I read that they used, which my concern with that would be what are the plateau pressures that that lung is experiencing? And then with that, you are then going down to zero PEEP, completely collapsing the alveoli, and then the shearing forces and the driving pressures that you're then experiencing to reopen those alveoli from completely nothing. Like when you just think about the compliance of the lung in that very low period, if you're not adding PEEP, that's the time where you're going to need a lot more pressure in order to open. So you are exposing those lungs to probably more pressure than, I would like to see. And I wonder over for these patients that are potentially bleeding and potentially in a traumatic arrest, they're already at an increased risk of ARDS, and then you're potentially going to be exposing them to these large pressures. It makes me nervous. Like I would definitely, I feel like I need to read more about it and to talk to people with larger brains than mine to explain the rationale and to show me how they think that this would still be lung protective for the patient. I would still argue, keep your PEEPs low, keep your pressures on the lower side, and you'd really have to show me and convince me that like high pressures and high volumes that you're going to be experiencing in these large areas would actually show you over time, a significant amount of lowered pressure over time to then show an improvement with blood pressure. So that's kind
Yeah.
of like my roundabout answer.
Yeah, I think that's the part that is like kind of a big unknown at the moment. It's like I think
Hmm.
it makes intuitive sense that this would like potentially like mitigate that effect of like dropping preload in a mechanically ventilated patient, but like at what cost? And
Hmm.
that's the unknown part. Like at what point does it like not become in the patient's benefit to do that kind of thing? And like I said, like we could almost always like leave the vent strategy alone and use other interventions to increase like to address the hypotension. Um, so it's not really like a doesn't much matter for most of us like where we practice, but it's more of like a question just like in the worst case scenario, like if you're out stranded on an island and all you have is your ventilator, which doesn't really happen to most of us, but
Yes. Hey, have a ventilator will travel. Why not? I had a
yeah,
BVM in my car for like years and years and years before I finally was like, okay, the expiry date is really past the point that I would ever want to use this. And also now I'm like, I don't really know if I want to have this in my car because I feel
yeah,
like I
you
have
might
to
get
use it.
stuck. Yeah,
Yeah, anyways, side note, but I would need to read more for sure. Like it's
yeah,
an interesting
totally.
idea, but like, hey, like pre-hospital blood, I'm on the train too. Everyone should have it.
Yeah, for sure. Um, you have mentioned a couple times in some of your posts about going with a tidal volume of 8 mils per kilo
Yes.
versus 6. Do you want to talk about that a
Yes.
bit?
Yeah. So for ARDS patients, that is the one population, and I'm speaking about adult ventilation here. But for ARDS patients or patients that are showing evidence that you're dealing with ARDS, that's the one patient population where I would say start at 6. But when it comes to any other patient pathology, and even when you look at ARDSNet protocol, as long as, like, if you had a patient that was acidotic, that as long as you had room in your plateau pressures, ARDSNet protocol taught you to go up to 8 mils per kilo. It would tell you to increase your tidal volumes by 1 mil per kilo until you got to 8 mils per kilo. And that is part of ARDSNet protocol. Like that is 6 to 8 mils per kilo within the protocol that we've been using, but everyone kind of micro focuses on the 6, which again, that is the initial settings for ARDS. But for everybody else, we know that 8, as long as your driving pressures and plateau pressures are within range, it gives you a much more effective alveolar ventilation. This is, just basic physiology. We know we have dead space. And now, with the emergence of, a bunch of literature looking at intermediate tidal volumes, there is this whole idea of this driving pressure, targeted tidal volumes that for patients that have higher compliant lungs, that they really can get larger tidal volumes. Some of the studies are going well beyond 8 mils per kilo, as long as your driving pressure is safe and, sub 14, 15, 14 in that range there. So again, I teach if you have room with your driving pressure and plateau pressure, consider, and you need to normalize gases, consider going up to 8 mils per kilo. And the new body of research looking at mechanical power and like all of these things are starting to like bring all these other ideas into the picture where we know that tidal volumes, keeping them low is not the only piece of the puzzle anymore. And if you just think about it intuitively, like if we are banging the crap of our lungs open and closed every single time we do that, that's going to cause trauma. We know that. So it's not just the amount of volume, it's not just the amount of pressure. It could also be the rate, and it could also be just the amount of power that we're pushing into the lungs from the vent. So there is more to the picture, and I'm not teaching beyond 8 at all. And please don't misunderstand me. And if your patient has ARDS, I still abide by the idea of starting at 6 mils. But if you have the ability and you need to normalize gases, going with a larger volume and getting to 8 mils per kilo, if it's safe with safe pressures, it's going to be more effective.
And then when you're, let's say, like hypothetically, we started a patient on 6 mils per kilo, and then the driving pressure is like 10, and the plateau is obviously fine. You're going up to 8, and then you're just stopping there? Or do you ever find a reason to go past that if the driving pressure is still low?
Great question. As of now, I am still maxing myself at 8 mils per kilo. And that we don't have enough evidence yet to go beyond that in my opinion for me to change my practice beyond that. Like I think the prevent trial was a really great study to start to look at that and to look at the intermediate volumes, but we don't have enough. I know that 8 mils per kilo is safe, and I know that it is even safe in ARDS patients. And until we have more data to show that for sure, in non-ARDS patients, going up to X number of mils per kilogram of predicted body weight with X driving pressure and X mechanical power is safe as well. I don't think that I'm ready to get there, but I think the next few years are going to be really, really interesting. Like just to remind people, like if you go back, because there's going to be some that listen to this, that probably it's gonna irk them. But if you go back to the ARDSNet study back from that everything is based on, it compared 6 mils per kilogram of predicted body weight to 12 mils per kilogram of predicted body weight. There was no in between. And the ARDSNet protocol went to 6 to 8. So that is all safe. We know that's safe. And now we're looking at the 10 to 12 range and what that means. And again, I'm not there yet. I'm not doing that yet. But who knows where the next few years will take us.
Okay, and then a follow-up question. So let's say we start someone on tidal volume of 6 mils per kilo, and we like did all of our math, so we come up to like a rate of 16 or 17. And then we increase our tidal volume up to 8 mils per kilo, and we're still safe. But now our minute volume is a little higher than our initial goal, and we see our end tidal start to drop. We're down to 30. What do you do?
Excellent question. And I think here it depends a lot on what's the patient doing. It depends a lot on like, your sedation and kind of your environment. Are you in transport? Are you not? Because I think at that point you can choose. If your patient is breathing and their intrinsic respiratory rate is on the higher end, then I would probably drop my tidal volume. But if my patient isn't, then at that point both numbers are safe. You can choose. I probably would still suggest dropping your tidal volume down because why not? It'll mean less pressure to the lungs. Less pressure is a good thing, and your rates aren't high. But if the situation was that I was at 8 mils per kilo and a higher rate, I probably would come down on my rate if I was at a rate of like 26 or something.
Right on.
And
Cool.
that's, I guess, the art versus I like
Yeah,
there. I'm
totally.
like, there's no wrong answer. Pick an answer and try
For
it.
sure. Right on.
One other thing I wanted to mention, Ryan, is like back to the situation of like trying to get to 8 mils. Like before I'll increase my pressures or, um, you know, if I was in like a PRVC mode, like increase my volumes right away for the vent to then decide or whatever, or in a volume control mode, I would probably optimize my inspiratory time if I have a ventilator that I have that option. So if I'm on a mode that has a TI, if I'm in a pressure mode of any kind, I would look to optimize time and use time to my favor and see if I can potentially get more volume with the same amount of pressure before I even go to increase pressures. That's kind of
Mhm.
one great tool that you can do as well in order to optimize that. So I'm sure you know,
Yeah,
Ryan, but others might not.
totally. And just to like clarify that point, so you're saying if you have somebody who we're currently the way we have the vent set up, we're getting that 6 mils per kilo, and you're trying to get more volume per breath, like closer to 8, you would just prolong your inspiratory time.
Yeah, and it doesn't always work. Like you have to look at your waveforms, and this is where like I am a huge proponent for if you're using a ventilator, you need to dive into waveforms because that is everything. And I again I feel like I'm preaching to someone that knows this. So um when it comes to looking at your inspiratory flow time curve, if you see that your inspiratory flow is not coming down to zero before the breath cycles into exhalation, because remembering that in any pressure mode that has an inspiratory time, your cycling mechanism is your inspiratory time. So if you are able to extend that inspiratory time, you will then get more volume. But if your flow comes down to zero and you extend your inspiratory time, you're going to end up with an inspiratory zero flow hold, which will not give you more volume. So you have
Right.
to know your waveforms and look at your inspiratory waveform to be able to see whether time will work in your favor or not. So normally the classic picture is you'll see your peak inspiratory flow, you'll see your flow start to decay on that decelerating slope that you see, but then before it comes, it cuts off and just falls off a cliff. And if you see that, then you know that you had accessible flow. You should see that flow time waveform coming close to zero to be able to determine whether increasing time will work in your favor or not.
Right. Yeah, and this is something that's cool now that the price point has really come down on the Hamilton, and everyone seems to be using those in transport like all over the world. Is now that we have access to those like waveforms and loops, which is pretty cool.
Yeah. Oh, you
Yes.
said loops. Oh, right. Loops. Do you use the loops on the Hamilton T1?
I mean, we look at them. The thing is, I'm not convinced that maybe I just don't know enough about it, but I think the loops give you information that you can also get elsewhere.
Yes.
So I'm not convinced that like you should go looking at the shapes of your loops to like make a diagnosis, but it can confirm something you know, or you can like see in real time as you're doing any intervention. But I don't know if I would like start there to go like troubleshooting what's going on with my patient.
Yeah, little pearl that I eventually I will get my Instagram posts to this point where I'm going to go through this and go on a rant about it. If you're using the Hamilton T1 and you are using your pressure volume loops, you don't know what you're looking at. And I say that with all the love in the world. And don't worry, because like I didn't have a good understanding either when I graduated as an RT. Um, Remember that the Hamilton T1 is a pressure ventilator. So the idea with your pressure volume loop, the best mode of ventilation to be able to look at a pressure volume loop and get information out of it is when you need a ventilator where everything is consistent except for one variable. So a volume control mode where volume is consistent per breath and flow is controlled will give you pressure being the variable that is changing. So with the loops, then you can look for your opening pressures, your closing pressures. You can look for over distension. And yes, it's a bit hand wavy with opening pressures and closing pressures on which one we use and all those things. But looking for those inflection points, like really, it has to be a volume control mode. So on the Hamilton T1, we know we don't have a true volume control mode. We are using a pressure mode of ventilation regardless.
Mhm.
And since pressure is limited and volume is changing and flow is changing, you blow past your inflection points with your pressures with it being a pressure mode too quickly because the vent is just cycling up and then it's flattening your curve
Mhm.
right when realistically you'd be getting your information about overdistension because we're limiting pressure. So with that, you lose all of that great information. So at that point, all you're left with is leaks, which you can see elsewhere, spontaneous efforts you can see elsewhere, and then also you're missing everything else that you could use them for.
So you would maybe look at a loop on like in a hospital setting, like where I work, like everyone is in volume control ventilation. with a volume control, like a true volume control
Yes.
ventilator, but not so much with pressure control, unless you're just like nerding out and trying to confirm what you think you already know.
Yeah, and I tend to even I don't use even loops that much in volume control, but I would use it more. So
Mm,
when it comes to like looking for the beaking, for example, that would show you over distension,
totally.
that's something that is very handy to look at for a volume control mode. But again, you'll never see that with a pressure control mode of ventilation, which is what we have on the Hamilton T1.
Yeah, I've only ever used them more for like curiosity's sake. Be like, oh, like this
Mhm.
is what I think is going on with the patient. Oh, I remember like what this shape is supposed to look like. So then you like pull it up. You're like, oh yeah, cool. Or like,
Yeah, and
oh,
then
maybe not.
the one thing that one of my amazing coworkers she teaches when she talks about loops is really the only thing you're really looking at is like the upright football means a more compliant lung. So if the
Yeah,
football drops to the
it
side and
tilts. Yeah.
the horizon, then you have a less compliant lung. But then you can look at your page 3 monitoring, just look at your CStat in real time. So there isn't enough value to lose both my flow time waveform and my volume waveform. Like keep your flow time waveform up on the screen is what I always tell
Mhm.
people.
Yeah, I think most people are just like pulling it up to like take it. Well, that's what I do. I just like pull it up and like take a peek at it and like flip through and like look at all the cool things that the Hamilton gives you. Like look at your dynamic lung and like your loops, and then you like put it back on your home screen because that's where you like need to keep an eye on things.
Yeah. Yeah, I
Um,
get it.
yeah. So you mentioned looking at your um, like using your waveforms to adjust your inspiratory time to decide if you can like give more or less time to maximize that tidal volume. What do you think if you had to like pick a couple of like important things for folks in transport to be able to like pick out of the waveforms at a glance? What's another thing or two you would put on that list?
Gas trapping. Like that's like
Okay.
hands down,
So just
hands
making sure like it like gets back to your set peep.
yeah. So making sure your flow time waveform it comes and even like your pressure waveforms, like that's not a good place to look at for auto peeping because the vent is going to show you on that pressure waveform whatever you've set. It won't read accurately the pressures when it comes
Interesting.
to I know. And this is if you read in the manual, auto peeping is a wild thing. And it's a little bit of a soapbox again that I could get on.
Yeah, because I was always taught to like keep an eye on the pressure waveform to see if it comes back to your set peep. Um,
Yes, but
But
it's
you're saying
always
it may
read that.
still show that it gets the peep, but it's not actually all the way there.
Yes.
Oh, interesting.
So when I teach, even like on page 3 monitoring, we have auto peep as something we can read.
Hmm.
I don't trust that. That is grain of salt, grain of salt. It's based on your settings and it's something that is calculated. But especially when you have auto peeping in the lung, it is a dynamic process that is not happening homogeneously through that lung.
Totally.
So with that, unless you can do a true expiratory hold to then get equilibration of pressure and actually read what is being felt with auto peeping, if it quacks like a duck, meaning if you see on your expiratory flow waveform that you're not getting back to zero, you have auto peep. Regardless of what your pressure waveform says,
Mm,
regardless of what auto peeping you have on the other end, that expiratory flow time waveform is the Bible that you need to follow when it comes to looking for auto peep. And until that flow time waveform comes back to zero, treat it like you're still auto peeping because it's going to underestimate in every other aspect what your auto peep is.
So you could have, just to like reiterate this point, because this is something that is new to me, you could have your pressure time waveform drop back to whatever baseline you have set as peep and still have, and your, on your like other pages in your monitoring on the Hamilton, it could say like auto peep is 0. But if you're seeing that the flow time, the flow waveform doesn't come all the way back to 0, you could still have some degree of auto peep in certain regions of the lung.
Yes, and to clarify, normally what'll happen is that your auto peep will be reading like point 0.2, something very, very small.
Mm,
But your expiratory flow time waveform is not coming back to zero. And what I can guarantee you, even if you froze your waveform and you scrolled back and you were reading your pressure and it's saying that you're reading like pretty much 5.1, 5.2, that is underestimating. That is underestimating 1,000%. That auto peep reading that it's saying is point 0.2 is probably a lot higher than that, and it's going to continue getting
mm,
worse.
right on.
And you can see this in the manual. If you read through the T1 manual, it says clearly multiple times that auto peep is estimated and that it should not be counted on when it comes to this. And there's also some really great studies. I can actually send them to you after. I'll look them up and send them to you that talk about the fact that unless you're doing a true expiratory hold, auto peep is always underestimated. So using that flow time waveform as what grounds you, as like there is auto peep and it's worse than I think, and fix it, fix it, fix it.
Right on. And how much of a like trying to think of like how to ask this question, like how much of a disparity is there? Like we often teach that like a couple points of auto peep is like not a big deal as long as you're not like seeing an increase, like as long as you're seeing a significant change. Um, so would you like always act on not seeing your flow time waveform, your flow all the way come all the way back to zero? Would you like just note it and see if it changes and gets worse, or would you always address it and get it back to zero?
I always try to fix auto peep. That is my my core in my body because it's hard to really tell until, later on. Now, there are situations where the patient is doing it themselves. Specifically, you can think about, obese patients or COPD patients where they end up doing it a little bit. So in those cases, I'm not too worried, but in like an asthmatic or a COPD, even them, I will still try to fix it by decreasing my rates. If my rates are greater than, 10 and I'm still seeing that flow time waveform come back to zero, I am decreasing my rates. So it's hard to say, like, because there isn't like one size fits all. Usually, I will always act on a flow time waveform that is not coming back to zero, unless I have
Yeah,
already got them down to, again, like sub 10 in my respiratory rate, and I'm still there, and the patient is seeming to be stable, and I'm still like going down every other route of trying to treat it in every way that I possibly can.
yeah, that makes sense. Cool. Anything else on the waveforms?
Oh my gosh, so much. I feel like I could talk about waveforms like
I think those are like two good, those are like two easy things to see.
yes.
Just
Yeah.
like, yeah, like you can see it at a glance. You don't have to like, yeah, you have to like look too hard.
And then like another one is leaks. And like all of these things as well.
Mm,
Like I have videos on my Instagram that kind of go through them for those that are listening that you can go and I walk you through auto peeping and leaks and how to recognize them and all these different things and just the basics of the waveforms in general. And I am at some point in the near future starting to move into all the worlds of the different asynchronies or dysynchronies, however you like to say it, that exist and how to recognize them and what to do about it and what they mean. And trying to, again, just do it in a way that makes sense and is really easy and approachable to understand. And it really isn't that hard once you know what to look for. So, like, I would say the three major things are the auto peeping with your expiratory waveform, leaks to be able to recognize them because they can really screw up what you're reading and what you're seeing. Remembering as well that the volumes you're seeing, specifically on the T1, but most ventilators, the volumes you see on your main monitoring panel is expired volumes. And so a lot of people don't understand that if they have a leak in place, that the volumes they're delivering are probably they are higher than that, and they could be beyond what is safe, especially when it gets to the tiny humans and ventilating the babies. And if they have an uncuffed tube, like this is very important when you're dealing with the mode of ventilation that you're in and all those things.
yeah, and just to clarify this point, because I think that's a really good point, is that when you're measuring your exhaled volume, it's only what comes out of the tube. So like
Yes.
you could put like 700 mils in and you only see 500 of it come out of the tube because the rest leaks around. So you could
Yes.
end up like giving a lot more air than you think.
Yes.
Yeah,
And
cool.
every modern ventilator should have a way for you to look through your monitoring to see what volume went in, and the vent will read it. But just
Totally.
recognizing that what is on the main screen as the default one you see, from every ventilator I've ever worked with, and there's a lot of them, it's always expired. And that's always something that kind of shocks people. And like if you're dealing with CMV plus on the Hamilton T1, or what's the other name for it, APV CMV or something,
Mhm.
um, that is a volume targeted mode that is targeting exhaled volumes and going to deliver pressures to hit that exhaled volume. So
Yeah.
leaks will work against you if you're not able to recognize them. And it's a very easy thing to see and to be able to then act on.
Yeah, I think the only exception in terms of ventilators that we still see out there that don't have a flow sensor to measure an exhaled volume would be the uh, what's the new name for the Zoll EMV or the old Eagle Med. Those ones don't have a sensor to measure like exhaled flow, but those are mostly getting phased out, but we still see them sometimes.
Well, and hey, not knocking vents that don't have a proximal flow sensor at the patient. I've used with many of them, and like my absolute favorite ventilator I've ever used, RIP PB 840, I loved you, did not have a flow sensor at the patient, and it read the volumes back at the vent, and that vent was brilliant. I loved it so much. It's gone now. I'm still crying about it, but um the vents are still great, but they still are reading what's coming back to the machine to then tell you on that main screen. And I didn't get to my third thing, but to say really quickly is auto triggering. That's the other thing that everyone should be able
Mm,
to recognize in a waveform.
right on. And we'll direct everyone to your videos if they're not familiar with that.
Yes, I go through all the different causes.
Cool. Um, how are we doing on time? Do you still have time? We got a handful
Yeah,
more
why not?
questions. All right.
Yeah,
Um, for troubleshooting, what are your thoughts on the dope mnemonic?
I love it. I do suggest the dopes with S's, as many S's as you can fit on the end. Because I think there is a lot of issues that come with ventilation when it comes to synchronizing. And I don't like the S being sedation. I like the S being synchronizing. If you have the ability to change your ventilation, even in micro amounts, to make it more comfortable, to mean less sedation, that is something that I would really strongly, recommend for practitioners as the next frontier in their ventilation skills. It might not be your first level, but once you're comfortable where you are, then starting to learn about trying to, look for those signs in the waveforms telling you your patient's uncomfortable. It'll mean less sedation, which will then mean a better blood pressure, which will then mean less inotropes or vasopressors. And like it feeds into a much happier transport for you,
Totally.
not just,
Yeah, yeah, and this is something that like when I was putting the vent book together, like a lot of how I talked about like adjusting things on the ventilator for patient comfort was more of like trying things and seeing if it works because this was like before the Hamilton was like readily available. So that's something I need to like revisit, like how to present that idea now that you have like data to look at. Whereas like, like sometimes you have somebody who like tolerates being in like volume control. This is like pre-Hamilton days just fine. And other patients like they're really uncomfortable on it, but you put them in pressure control and it works. And like prior to waveforms or like without waveforms, like it's kind of like hard to like you're just like kind of guessing and trying different things. But I think now there's maybe a better way to present that where you're like looking for specific things and making changes based on that, such as like like having a strategy for like how you're adjusting your inspiratory time, or yeah, that's something I need to like maybe like look back over on the next version, like refine a little bit.
mhm.
Especially like almost everyone now is using the T1, so we have like a lot more data than we did before.
Yeah, and that frontier I think is such a like it is my favorite realm of ventilation. It's an area that I am still like daily obsessed with and am reading about and feel like I am nowhere near the pinnacle of what I can possibly learn. And I do want to just encourage everybody that feels a bit overwhelmed that like this was not stuff that was covered very well when I went to RT school. Like that was, you know, 18, 19. Okay, yeah, not almost 20 years ago that I started my RT school, and that like vents were just starting to have waveforms. I was still working with ventilators in an ICU that did not have a screen, that had numerics just like you would have seen like the LTV that like spit out across the screen and you have to scroll through. So waveforms were the next level, and some vents had them, some did not. And then starting work and starting my clinical, yes, most vents did, but then it wasn't something that really was fit into the program very well. And I know a lot of RTs that are graduating, it's still something that they don't feel was covered as well. So it's something that a lot of RTs are still learning as well. So don't feel like it's scary too far or too outside the realm of what you could know. It's not. It's actually once you understand what you're looking for and once you can recognize normal, that is where you start. recognizing normal, and then recognizing when something does not look normal. And then the rest is gravy. You just start
Totally.
to look at your patient and why would your flows go up or down? What could be happening? And then
Mhm.
it all falls from there.
Yeah. Yeah, that totally makes sense. I mean, same thing, like that's kind of how we, or at least when I was learning EKGs, we taught them the same way. Like you need to look at like do 12 leads on all your patients for the first year or two so you can like identify what's normal. And then when you see something funky, you may not know what it is, but you're like, okay, like I got to figure this out because like something is not normal.
Yeah.
Yeah, I think that's a good approach. Um, just to loop back to the dope question, the reason I asked that question is because I tend to be like a anti-dope mnemonic person. I think I'm like anti-mnemonics in general because I think like a lot of times we have so many to remember, and then like oftentimes you can like remember the letters, but you don't actually like remember what they stand for. I think they can like hang you up a little bit. We also like I have noticed in transport we tend to like teach that the dope mnemonic addresses like all the possible problems you could run into with ventilation, which is definitely
Mhm.
not true. Um, so yeah, like I sometimes I'm not convinced that it's like the best framework for like approaching problems, but I think like as long as you're aware of the limitations, I think it's like totally fine to use. I just yeah, I think we sometimes assume it is like a yeah an all descriptive like recipe for figuring out what's going on with the ventilator, and that's not necessarily the case.
I agree with you 100%. Like, to be very transparent, the last time I actually thought about dopes in my actual practice, oh my, I don't even, I can't remember. I can't remember.
Right.
And it's like now when I walk to a bedside, I am using my eyes, I am using my hands, and I am using like I can look in the waveform and know what's going on. Like pretty much if you show me a waveform, I can tell you what's wrong. Like the ventilator, like it's very easy to tell. Like I can feel the circuit and I know whether I need to suction my patient. Like it's I can look at my patient and how they're breathing and see the problem. So you evolve past that, but sometimes in a time of cognitive load, like having the dopes mnemonic to fall back on, um, especially if you're newer in your journey, I'll never knock it. Never, not once, because I
Yeah.
think it will save a lot of people in a situation of like, I don't know what to do. Well, one of the S's is sedation, so I can't fix this. I don't know what's wrong. So, okay, I guess we're at the point where we're calling for paralysis and extra and more sedation. And that's okay. Like safety is paramount and we need to be safe for our patients. And if you don't know what's going on, disconnect and beg. If you can't fix the problem or, it's not begging and it's the patient fighting, then there is always other things you can do in order to fix it. So, I don't know. I think people do evolve past the mnemonics. I very much agree with you. And I think there is a point where it doesn't serve the purpose anymore, but I will never knock someone for needing it or needing to rely on
Yeah.
it.
Yeah, totally. Same thing like I don't yeah, like in our EMT or like even first responder classes, we teach like this thing called DCAP BTLS, like
Yeah.
all of the injuries you could see when you're like doing your assessment. Like
Yeah.
everyone like memorize that, but eventually you get to a point where you don't actually like need to rehearse them out loud every time you like assess a patient.
Yes.
Yeah,
Yeah,
cool.
absolutely.
Um, you talked already about you mentioned it twice, like paralysis in transport. I think that's worth like discussing a little bit more. Um, I think there's generally like mixed opinions on this. Like
Mhm.
one take is that we shouldn't paralyze our patients because we want to support spontaneous ventilation, and there's like a whole bunch of advantages to that. And then the other side is that you are also responsible for keeping that tube where it belongs, like in the correct spot, and paralyzing them allows you to do that better. I was curious to know like your thoughts in transport or what your practice is when you were flying.
I can count on less than 3 fingers how many patients that I personally paralyzed in transport. Um, I do have to preface this with the fact that in my flight environment that I worked, we were, like pre-hospital flying up to remote communities that we did not do a lot of IFT transfers, like, from facility to facility. So I'm sure there with doing interfacility transports, I probably would have come across way more patients who were already paralyzed or already further along in the course of their disease that they would have required paralysis. But of the patients that I transported, and a lot of them vented for long periods, like I always tried to gently remind people, like that some of the transports I did was upwards of greater than 7 hours. I was flying insane distances. Um, and I didn't have to rely on that. I flew in a lot of extreme weather conditions, and there were times that I had to give a lot of sedation or give a bolus, but I tended not to fall on, paralysis. Now, again, I've said this as well before, but I'll say it again. I will never knock a provider for going to paralysis if there is a concern. There is a degree of comfort that I have with being able to recognize when a patient starts to rouse and wake up. I can see it in the ventilator, in the waveform, and I also always, always, always carried very, very easily accessible medications to deepen them, um, and also pre-dose them when it was coming to a situation about going into minus 80-degree wind chills, which I would be exposing them to. So, all this to say, that's how many times I've done it in my practice. I don't think it's needed as much as it's done. But again, if it comes down to safety as the need, I would never ever question a decision.
Yeah, I'm kind of the same way. We like very rarely will paralyze a patient. Um, but that said, like I think there's like the maybe a misunderstanding that like paralyzing a patient is like dangerous for the patient. And I think sometimes that maybe is like a little bit overblown. Like I think it's totally fine in most cases. Like if you paralyze a patient to get them through like a bumpy section of road or while you're like loading them, like I think it's yeah. Like I think like in years past, I would have maybe had like stronger opinions on that. Like oh, like don't do that because we want to like salvage whatever like spontaneous effort they have. But I think like with time, I've kind of realized that like it's probably just fine.
Mhm. And I think the caveat I would say on the other end is like going back to the beginning when I talked about like my job as an RT is to get someone off of the ventilator as quick as possible. I really did fly by that mantra as well. And like the other side of dropping a patient off at a hospital is something that a lot of people in transport don't necessarily see. And I can truly say, especially when receiving a patient from a critical care flight team, I'm not going to change their settings. I'm going to copy their settings, whatever they're on, and I'm going to put the patient on the same settings. And if they're paralyzed, that means they're on a control mode. And then by the time the nurses do the bed move and they, get the patient settled and they get all the monitors on, and I'm allowed to go back into the bedside to even get a gas or ask for a gas or have a gas drawn, most likely the actual timeline after the patient arrives in the hospital that they are going to have a vent change done is going to be at least 4 hours later, if not potentially a little longer. There are some hospitals that don't lean on nights and don't make changes on nights. Like I see, there's a whole range of things. So whatever length your transport was, if they're paralyzed, even with a paralysis waking up, if they turn the paralysis off and lighten them, it's going to be a lot longer clinically for that patient to be on a ventilator versus if they were in a control mode and breathing above and they got transferred over and that stimulation made them breathe a couple more points. As an RT at the bedside, I might be like, I'm going to flip them to pressure support and see what they do.
Right.
So that might then accelerate that patient by 2, 3 days.
Yeah. That's a significant time. Yeah.
So is it harmful? No. Safety in transport is paramount, and I agree with you. It's not gonna hurt your patient to paralyze them, and if it makes it safer, then absolutely do it, 100%. Um, but if it means getting that patient off the ventilator even 1 day sooner, that's something to think about. It's food for thought if there's a way to do it
Yeah.
safely.
Right on. Cool. I just had one other thing to chat about. Um, what do you know about volumetric capnography?
Not a heck of a lot. You threw that question at the end, and I was like, "Oh," like, I'll be honest, but I like the question. I didn't tell you I didn't wanna talk about it because I think it's important to really stress the fact that I don't know everything. I read a little bit of the studies on it, and I say it looks kind of cool. I'm intrigued. I'm interested. I'd like to see more, um, to or and probably get my hands on it and play with it a bit. Have you had a
Yeah,
chance to use it?
I only have like read about it. Um, but I have a like my understanding of like the tech, and I guess maybe we can give like a little bit of background, but the idea here is that you can measure like the quantity of CO2 that is exhaled instead of like the way we do capnography, you're just measuring like a peak concentration. You could actually measure like in milliliters or liters, like how much oxygen is being exhaled with a breath or over like a given amount of time. And I think the advantage, if I recall right, it's been a while since I looked into this, is that it would allow you to accurately measure what dead space, like what the patient's dead space is.
Yes.
Um, and I think that provides a lot of value because dead space is kind of this like elusive, like complicated idea that like makes mechanical ventilation like really intimidating for a lot of people. Um, but I think we tend to like overthink the problem. Like there are some things we can do in transport or even at bedside to like minimize the effect, and after that, like that's kind of all we can do. But I think being able to see it in real time, like when you pop whatever little gadget you have in the vent circuit out and see how it changes, I think like something like that would be like highly advantageous, even if you didn't have it like on all the patients you're ventilating, but like if it was available in sim labs or even like on non-invasive, so you can like demonstrate to somebody. Like I think that technology would be like really good for like learning and teaching, even if you didn't have it for every patient.
I think it would really help, give a number to those people that need numbers in order to have them start to, like, flex their targets when it comes to ventilation and really drive home the point that sometimes a slightly larger breath and a slightly lower rate is more effective. And if you look at the math, it makes sense that like you are actually clearing CO2 at a better rate.
Totally.
Um, so I think it would help for those people that struggle with that, that like don't understand. I don't understand. I'm increasing my respiratory rate and my CO2s aren't coming down. Why not? And it's like because you're barely changing anything because the volumes you're giving are like barely clearing dead space.
Yeah.
So it would help. I think the thing that also gives you that value already and not a quantifiable, not like a number that you can actually look at and like hold in your hands and tangibly and say like this is how much of my volume is getting in. But like when you correlate your gases to your end tidal, you're already really looking at that relationship and seeing the like how much of an issue you have in VQ matching, and that then can lead you down the path of like, can we optimize this in any way and can we improve, and then kind of lead you down the path of like, is PEEP going to work in our favor or not, using physiology as your grounding. So, but I like the idea of a number for those people that need it in order to be able to start to ventilate more effectively.
Yeah. And I think the point you make about gases definitely makes sense, but in transport, we oftentimes like we don't have that, or we have like a single data point. Like even places that are doing gases, they will do one, maybe like a second one on arrival. But like in the hospital setting, you can like get those every 4 hours for like, you might have the same vented patient for like 3 days. So you can like trend it and see how it goes. But
Mhm.
that's something that like a lot of folks in transport just like never have had access to. They just, it's like out of our, yeah, not really out of our, I don't know what it is. We just don't see patients for that period of time. Like you're not able to
Yeah.
like appreciate those trends. Um, but something like being able to like, yeah, like eventually I think the tech will be there where you just like your end tidal detector on your monitor will like measure that capnography like in terms of a volume, not just like a single number. Um, I imagine that will exist
And I
someday.
think the dead space specifically is going to be like a benefit. I really do. I think I do want to see it a bit more in use and like maybe studied against like those patients where we're using blood gases, because I would love to see the value of having every service that has ventilators have a point of care machine, because I think there is
Mm-hmm.
value in actually targeting and chasing the number that you should be chasing instead of a bad reflection that sometimes doesn't even reflect the thing you should be chasing. So,
Totally.
like at the end of the day, pH is what we want, not PCO2 and not end-tidal CO2. Like pH is where we want to be. And if you don't know what compensation your patient has and what process, like you could be chasing a completely different animal. And
Yeah.
so I think like I would love to throw my support behind something like that. And yes, the machines are finicky. iStat versus Epoch, I've used them both, and both have their drawbacks. But like it's still the value you get back is so high. So that's kind of my stance on that. But I'm curious to see where the volumetric end title
Yeah.
goes.
Yeah, and I think even for places that don't like carry their own iStats, like a lot of hospitals now like have like point of care tests like in the ICUs or in
Yes,
the
the gem
ERs.
machine. Yeah.
Yeah, like a gem. So you even if it's not like part of your like program's capabilities, you can still like they're gonna run a gem as soon as that patient gets set up. So just like hang around for 15 minutes and like take a look at it. And then you can like get an idea like, I
Yeah.
was like ventilating my patient to this like goal end title, and then I like look at their gas and they're actually like, oh man, their like pH like got worse. Like maybe I should have ventilated them to like a lower goal. Like you can like adjust your strategy a little bit, um, just with that like receiving hospital's data point, even if it's
Mhm.
not part of like what you're doing clinically.
Yeah, absolutely. It changes what you're targeting for sure.
Yeah, cool. Well, that's all of my questions. Is there anything else that you wanted to mention or that you thought about?
Um, honestly, like I feel like we could talk all day. Like there's so many things, and I think this was fun. Like we had some tech issues in the beginning, but it was a lot of fun.
We figured it out.
We did. And I feel like I don't know enough about you, Ryan, but I feel like I won't bore the podcast with asking you questions about you. Instead, I'll just bug you on Instagram.
All
But
right,
I
perfect.
for everyone just that's listening, if you want to follow me, if you're interested in hearing more and like feel free. I love being a resource. And you can find me on Melody Bishop _RT. Um, but
And I can
otherwise, just
attest to that because she puts up with all my questions.
I really do. Like I want to be a friendly neighborhood RT that people aren't scared of asking anything that they think is a stupid question, but I can guarantee you it isn't stupid because I've asked way stupider ones in my life. So it is I just want to be an easily accessible and friendly person that you'll never feel stupid to reach out to.
Awesome. Well, we appreciate that.